It is my pleasure now to introduce our colleague, Dr. Stela Vujosevic from Italy. She will speak about the indication and result of micropulse laser in diabetic macular edema. Stela.
Hello everyone, it's my great pleasure to present this presentation today during the European SOLS webinar on the indications of use of micropulse laser in DME, evidence and practice. I'm sorry not to be able to be present during the discussion due to the flight schedule changes. So the subthreshold micropulse laser represents a revolution in retinal laser technique. It has shown to be safe and effective treatment that does not destroy the retina, but it normalizes or restores its normal function. However, the lack of standardization has limited its use in everyday clinical practice. The therapeutic mechanism of action is still not completely understood. However, it acts as a physiologic reset stimulus, improving and thus normalizing RPE and retinal function by activating RPE heat shock proteins and also by the decreasing of the production of different inflammatory cytokines, including those that are released by the glial retinal cells, and also it decreases the production of VEGF and matrix metalloproteinases. So the safety and efficacy of micropulse laser have been reported by several prospective randomized studies, and its effect on the retina have been evaluated by different imaging modalities, such as the fundus color photos, optical coherence tomography, fundus autofluorescence, fluorescein angiography, and more recently also by the use of OCT angiography. In this meta-analysis of randomized clinical trials that evaluated and compared subthreshold micropulse laser and also standard laser treatment in DME that lasted for at least 1 year, found that the subthreshold micropulse laser is the one that gives better functional results in the terms of the increase in best corrected visual acuity. And also we found an increase in best corrected visual acuity. We see of approximately 5 letters ETDRS in patients with DME treated with micropulse laser after 9 months of treatment, but not only visual acuity increased, also central retinal sensitivity increased, which was measured by microperimetry. And the anatomical results that were evaluated with the central retinal thickness were, and also the changes in retinal thickness of different retinal layers were significant, a little bit further along the follow-up. So you can see after 12 months of treatment, we found a significant decrease, especially in the inner nuclear layer. The inner nuclear layer is the one where we know that hosts the nuclei of the Muller cells and also the deep capillary plexus. So when we evaluated these patients with both OCT and OCTA, we found that the micropulse laser can improve microvascular modifications in both retinal plexuses, but especially in the DCP, and that there was a decrease in the number of the microaneurysms, which we know are not the direct target of the micropulse laser treatment. We found an increase in best corrected visual acuity after micropulse laser treatment, a decrease in the, as I said, in the number of the microaneurysms, both in the superficial and in the deep capillary plexus, a decrease in the cyst area in both plexuses. And also we found a decrease in the number of hyperreflective spots as the sign of the activation of the microglial cells, so the decrease in the, let's say, inflammatory biomarkers within the retina, and also the decrease in the extension of drill. The drills are the disorganization of the inner retinal layers. So the evaluation of specific parameters in the deep capillary plexus may help in determining the response to treatment. Whether this effect of micropulse laser on glial retinal cells is direct or mediated by the RPE has still to be evaluated and confirmed. However, these findings suggest that micropulse laser might be able to down-regulate the inflammatory retinal processes activated by hyperglycemia in patients with diabetes mellitus. So the current indications for the treatment with micropulse laser in DME could include the mild center involving DME with good visual acuity, not center involving DME. It could be used in combination with intravitreal injections. It can be used in patients who refuse the injections and also in pregnant patients. So let me show you some of our cases. This is a young lady with type 1 diabetes mellitus and a long duration with quite good glycemic control. We can see very good visual acuity in the right eye, 85 ETDRS letter score, and the initial decrease in visual acuity in the left eye, so 82 letters ETDRS score. On OCT, you can see that there is initial edema, center involving edema in her left eye. This is fluorescein angiography of the right eye, and this is fluorescein angiography of the left eye, where you can see the leakage in the macular area and also the cyst in the very center of the fovea. Here you can see even better the OCT and also OCTA of all of the three plexuses within the retina. So we decided to treat this patient in her left eye with the micropulse laser. And here you can see the results after 6 months of treatment. You can see the decrease in the cysts in the central retina. You can see an increase in visual acuity. Now it is 85 letters ETDRS score. And you can see also the microperimetry exam of well-preserved retinal function. Here you can see these details even better of the change in retinal cysts on OCT. As there was still some mild edema, we decided to treat again this patient, and this is the follow-up 1 year after her second treatment. So you can see here very well how the cyst progressively decreased, and after 1 year after second treatment, there was no signs of edema anymore. So the subthreshold micropulse laser can be used, as we said, also in combination with intravitreal injections. And this was a recall study that was a single center phase 4 prospective open label and randomized controlled trial performed in Germany, which compared the intravitreal injections of ranibizumab only for DME versus initial treatment with 3 doses, monthly doses of intravitreal ranibizumab, and thereafter subthreshold micropulse laser. What was found in this study after 1 year of follow-up is that the patients that were in the combined treatment groups had fewer injections in 1 year. So it was 7.46 injections of anti-VEGF drug versus those that were only in the anti-VEGF drug treatment group, so 9.68 injections. The other parameters, so the best corrected visual acuity change and the central macular thickness change, were similar in the two treatment groups. However, there was a tendency for a greater improvement in best corrected visual acuity in the combined treatment group versus the only anti-VEGF treatment group, even if this result did not reach statistical significance. This is the example from our clinical practice. You can see this massive center involving edema with this huge intraretinal cyst and also this big subfoveal retinal detachment, very low visual acuity, only 35 letters CTDRS. The patient was first treated with a steroid, and you can see 2 months after the steroid treatment, it was visual acuity was 55 letters, so an increase in 20 letters. Here we added the subthreshold micropulse laser, and 3 months after subthreshold micropulse laser, there was further increase in visual acuity of 5 letters, so it was 60 letters ETDRS score, and progressive decrease in macular edema. Recently, the data from the Diamond study were published, and the Diamond study was a pragmatic, investigator-led, multicenter, randomized trial that was performed in 16 centers across the UK, and which compared subthreshold micropulse laser versus conventional laser in patients with diabetic macular edema and central retinal thickening inferior to 400 microns. The primary outcome was the mean change in best-corrected visual acuity in the study eye from baseline to month 24. Here you can see all different secondary outcomes, which included different functional parameters, obviously change in central macular thickness, and also the quality of life of the patients. So the primary outcome was met, and the subthreshold laser was non-inferior to standard laser treatment, and it was deemed to be also equivalent to the standard laser treatment. Also, the major part of the secondary outcomes were not different between the two treatment groups. So the only secondary outcome that was different between the two treatment groups was the mean number of laser treatments. That was a little bit higher in the subthreshold micropulse laser group compared to the standard laser group. So the conclusions of this study was that as the micropulse laser was equivalent to the standard laser for the treatment of center involving DME and central retinal thickness inferior to 400 micron, and as it is cheap and effective treatment, these patients should not be left without treatment, but should be treated with a subthreshold micropulse laser. And this was all from me. Thank you for your attention.